Material risk like endocarditis or arrhythmia, paroxysmal embolic events, heart failure, pulmonary hypertension, even also death. Risk factor for the developing of heart failure. When there is respiratory or urinary infection, factor for the development of heart failure B. Treat the respiratory infection, the possibility of heart failure. Anemia also may lead to the heart failure. Corticosteroid use, diabetics, multiple hypertension, arrhythmia, pain-related stress should be prevent any pain and should be treated and managed accurately to prevent the precipitation for the heart failure, fluid overload. So, if the patient under this condition may lead to the heart failure, should be treated and managed as a non-pregnant one. No difference at all. What about the management of labor and delivery? Management of labor and delivery in the women with the heart disease should be in the tertiary center and avoid induction of labor as possible as use prophylactic antibiotic for the indicated patient, ensure fluid balance, avoid the supine, discuss vaginal and epidural analgesia and anesthesia with senior. Keep the second stage labor short. How? By use or decrease the load on the heart. Use of oxytocin or what is called syntocinon if there is indicated only. The methergine one, which is used in the management of third stage of labor, it is contraindicated because it leads to the vasoconstriction and increase the heart blood pressure and increase the heart load and may precipitate to the heart failure. Everyone should know the methergine or ergometry is contraindicated in the patient with the heart disease. What are the strategies of anticoagulant regime in pregnancy? There is a three strategy. The first one, continue warfarin during pregnancy, even when its teratogenous effect, or replace by warfarin with high-dose heparin from 6th to 12th week of gestation to prevent warfarin teratogenicity and 10 days before the delivery. 3. Use of high dose on unfractionated or low molecular weight heparin throughout the pregnancy. These three strategies, how can be used each one? Which option is chosen will depend on several factors. The first, type of mechanical valve. The risk of thrombosis is less with the newer bileaflet valve than the first and second generation ball and gauge valves. The position of valve replacement is important. Mitral position more risk than aortic position to thrombosis. Number of mechanic valve. When there is two valve, give half of thrombosis and one valve replacement. The required to maintain a therapeutic and any history of events. Also, we can, according to the risk of bacterial endocarditis, can use antibiotic. The high risk patient, it's the prosthetic valve, previous bacterial endocarditis, complex congenital heart disease, transposition of great artery, surgical systemic pulmonary, acquired valvular disease, and hypertrophic cardiomyopathy, mitral valve prolapse, regurg. So, for high and moderate risk, for endocarditis, prophylaxis is recommended. Thank you. Good morning, everyone. Today, our seminar about the heart disease problems in pregnancy, how can manage it during pregnancy and during labor. We start with the physiological effect of pregnancy on the cardiovascular system. By 6 to 8 weeks, peripheral vasodilation will occur, and this leads to decreased systemic vascular resistance, and there is increase in cardiac output by 20%, and increase this cardiac output maximum to 40% by 24 to 28 weeks of gestation. So increase the risk of the heart failure in this period. And heart rate will be increased 10 to 15% and increase cardiac output to 80% above pre-labor value in the first few hours after delivery and then return to the normal after 2 weeks post delivery. So the time important and the high risk of heart failure will occur post delivery immediately because high increase in cardiac output and the heart is already compromised and cannot tolerate this increase in cardiac output. How can counsel the patient with the heart problem? The first things we discuss with the patient about the risk of the maternal death and the possible of reduction of the maternal life expectancy and effect of a pregnancy on the cardiac disease. And there is also mortality associated with the high risk condition, risk of the fetus to develop congenital heart problem, risk of preterm labor and fetal growth retardation, need for the frequent hospitalization and possible admission frequently, intensive maternal and fetal monitoring during labor and during the pregnancy. Other options may be there is an contraception, adoption, and the surrogacy timing pregnancy after hair condition. What about the antenatal management? Should be at joint obstetric and cardiac clinic. So the cardiologist doctor should be introduced in antenatal management of this patient. When the patient come to us, should we start with the history? What about the history? History about her condition, how long she know about her condition, type of condition, is congenital or acquired, any operation done for for this problem, any medication take till now, and its level of activity, and any short of a breath with with a mild activity, without activity, with the strong activity, any previous attack of heart failure, any problem of thrombosis and DVT or pulmonary embolism, and also this question should be recur in every visit, and the visit for this joint clinic should be frequently more than the normal person. Also, examination starts from the weight, any general examination for anabella, for any cyanosis, for any jaundice, for vital signs, for any edema, especially for the sacral edema, and any basal crepitation, the first sign of the heart failure, and investigation for blood chemistry, anemia, general examination, culture, blood urea, serum creatinine, and even echocardiography, because ECG is not helpful in the pregnancy due to the pregnancy change the position of the heart. Also should be investigate for fetus. For what? For fetal well-being, especially in the last few months in the second trimester and third trimester, to the check the fetal well-being and fetal growth, because the patient high risk for the fetal growth retardation. for timing of pregnancy, and then follow up the maternal and fetal wellness must become also frequent more than the normal patient. How can we classify the patient? Can be classified according to the New York Heart Association classification to the mild, moderate, severe case. And the mild can be also divided into type. Mild one with no limitation of physical activity, ordinary physical activity does not precipitate fatigue, palpitation, dyspnea, inguinal pain. The second line, it is mild, slight limitation of the physical activity and comfortable at rest, but ordinary physical activity result in fatigue, palpitation, or dyspnea. And moderate one, marked limitation of physical activity, comfortable at rest, but less than ordinary activity cause fatigue, palpitation, or dyspnea. Also severe. Last one, it is unable to carry out any physical activity without discomfort. Symptom of cardiac insufficiency at rest. If any physical activity is undertaken, discomfort will be increased more and more. So this is a classification called New York Heart Association classification of this patient with a heart problem. Also, there is other mark for the to know what about the risk mark for the maternal cardiac event. This for what marks? Marks for any risk for the heart failure during a pregnancy. If the patient have zero predictor, risk of cardiac event is 5% only. If there is one predictor of above risk, the risk of cardiac events as heart failure is 37%. If more than one predictor, the risk of cardiac events is 75%. High risk cardiac condition so can be summarized when there is systemic ventricular dysfunction, ejection, ejection fraction less than 30%, or when this New York Heart Association class 3 or 4, when there is high pulmonary hypertension, cyanotic congenital heart disease, aortic pathology. If there is dilatation of aortic root more than 4 cm, because there is risk of rupture this aortic root, Marfan syndrome, and ischemic heart disease, left heart obstruction lesion like aorta, mitral stenosis, and prosthetic heart valve, metal, and previous peripartum cardiopathy. What's the risk of maternal cardiac disease? Recurrence. Recurrence congenital heart disease. The fetal may will be inherited congenital heart disease. Maternal cyanosis lead, lead to the fetal hypoxia, iatrogenic prematurity, fetal growth retardation, and effect of maternal drugs may lead to the teratogenesis like the warfarin or growth restriction or even fetal